My name is Ajay Nooka. I'm the director of the myeloma program at Emory University. We presented the results of the efficacy and the safety of Elranatamab. This is a BCMA bispecific antibody among patients who had seen prior BCMA-directed therapies. As you're aware, BCMA is a target that is present on the plasma cells. Elranatamab binds to not only the BCMA target, it also binds to the T cells, allowing for the T cell redirection and killing the myeloma cells. So elranatamab is not approved at this point as we speak, and the studies that were done on elranatamab shows that the overall response rate is in the range of around 61%, and those patients that respond, that receive this drug and respond, continue to derive this response for a very long time. So how is this trial very different than what was presented in the bispecific antibody trials? So this trial is a pooled analysis of 4 different trials that went on and specifically looked at patients that have previously received a BCMA antibody drug conjugate like belantamab or a BCMA CAR-T like ide-cel or cilta-cel. For those patients that previously have received a BCMA targeted therapy, would you expect to see any increased toxicity, or are you able to see those responses at all? So there were a total of 87 patients that were enrolled on this trial. 59 of them received a prior belantamab, 36 patients received a prior CAR-T, and these patients have been thoroughly, heavily pretreated, and they received around 7 to 8 prior lines of therapy. If you look at penta-drug refractory, that means refractory to 2 IMiDs, the Revlimid and pomalidomide, 2 PIs, which are the bortezomib and carfilzomib, and a CD38 monoclonal antibody, which could be isatuximab or daratumumab. So this is called a penta-refractory patient population, and these patients don't have a lot of options. And now 85% of these patients that were on this trial were penta-drug refractory. Not only that, they received an extra drug, which is the BCMA-directed ADC or CAR-T, so which makes them hexa-refractory. And these patients, we don't know what to do with them. And could giving this elranatamab be beneficial for those patients? So that's a question that was asked. And surprisingly, the overall response rate, around 50% of these patients responded to the current treatment. If you break down by patients who received a prior BCMA-directed CAR-T, the response rate was 52%. And if the patients received a prior ADC, which is belantamab, the response rate was 42%. These were very high rates. So to summarize, of these 87 patients, 40 patients responded, and among these 40 patients, 20 patients continued to derive this response when we analyzed the data. So the duration of response among those patients that are responding, the responses lasted for 17 months, so which is very good. And this whole population had a progression-free survival of around 5.5 months. And for those patients that received a CAR-T, the progression-free survival was 10 months. And those patients that received belantamab or ADC, the PFS was close to 4 months. The median overall survival was close to 12 months across the population. Now, the biggest question is how safe it is for patients who received a prior BCMA, CAR-T or ADC to receive another BCMA-targeted agent, here the bispecific antibody. And what we see is it is very safe, similar to what we're seeing in BCMA-naive patients. That means who have not seen a prior BCMA-directed therapy. And the hematological side effects like anemia, hemoglobin low, the low platelets, the low white cells, all of them were similar to what we're seeing in BCMA-naive patient population. There are two safety signals that we always want to talk about. In fact, I would call them 3 safety signals. One is infections. So what the increased risk of infections when you got repeatedly exposed to an antibody, bispecific antibody, the BCMA-targeted bispecific antibody, the infections were not as high as were reported in the BCMA-naive patient population. There were COVID-19 related treatment adverse events seen in a quarter of these patients. The second one is, are there increased risk of CRS? The answer is no. It is similar to what was seen before. CRS was mostly grade 1, and it was seen in 2/3 of the patients. and this resolved in 2 days. Is there any neurotoxicity, which is the third one? So the answer is it is no different than what was seen before. Overall, it happened in 6 of the 100 people. And when people had neurotoxicity, it could be headaches, seizures. When that happened, it only lasted for 2 days. So overall, we have a new treatment modality for patients who had previously seen a BCMA-targeted ADC or CAR-T. So this should be good news for the patients. And this would be an option that could be available for the patients that have previously progressed on a CAR-T.